Hey my badass doctors, today we have a 52-year-old man who presents to your office for an acute visit because of coughing and shortness of breath. He is well known to you because of multiple office visits in the past few years for similar reasons. He has a chronic smoker's cough,
Care if I smoke?
but reports said in the past 2 days his cough has increased. His sputum has changed from white to green in color, and he has had to increase the frequency with which he uses his albuterol inhaler. He denies having a fever, chest pain, peripheral edema, or other symptoms. His medical history is significant for hypertension, peripheral vascular disease, and 2 hospitalizations for pneumonia in the past 5 years. He has a 60-pack-year history of smoking and continues to smoke 2 packs of cigarettes a day. On examination, he is in moderate respiratory distress. His temperature is 98.4 degrees Fahrenheit. His blood pressure is 152/95. His pulse is 98 beats per minute. His respiratory rate is 24 breaths per minute, and he has an oxygen saturation of 94% on room air. His lung examination is significant for diffuse expiratory wheezing and a prolonged expiratory phase of respiration.
Big fella. Well, okay.
There are no signs of cyanosis. The remainder of his examination is normal. A chest x-ray done in your office shows an increased AP diameter and a flattened diaphragm, but otherwise he has clear lung fields. What do you think is the most likely cause of this patient's dyspnea? Well, just like these cute puppers who found their breadcrumbs, let's find ours. Alright, you have a middle-aged man with an acute presentation of coughing and dyspnea. What could have triggered this? Well, you know that he's been dealing with chronic smoker's cough, so these 3 words should ring a bell for a certain diagnosis. Then you learn that he has sputum production with a change of sputum character. Bingo, this is your next breadcrumb. And the case gave us a significant clue that he has a significant history of smoking. Bad habit to keep, but important for us doctors to know. You know his vitals are a little out of whack, but he's still afebrile. So as we know, blood pressure that's considered normal is anything between 90/60 to 120/80 millimeters of mercury. Too low, you're hypotensive, or if it's too high, it's hypertensive. As for pulse, which is used interchangeably with heart rate, it's typically between 60 to 100 beats per minute. Too slow, then you're bradycardic, and too fast would be tachycardic. Respiratory rate is typically between 12 to 20 breaths per minute. Ideally, we would want a lower resting respiratory rate and heart rate as seen in active, athletic folks with stronger hearts. As for body temperature, we know that this can vary depending on how active a person is or the time of the day, but typically the normal body temperature ranges between 97 to 99 degrees Fahrenheit. Average body temperature is 98.6 degrees Fahrenheit or 37 degrees Celsius. Generally, older people have lower body temperatures than younger people have. And finally, a pulse ox should read between 95 to 100% for oxygen saturation. His lung examination tells us about the expiratory wheezing, which should indicate that he has narrowed airway obstruction. Then the cherry on top that should confirm your working diagnosis is his chest x-ray result. Having increased AP diameter and a flattened diaphragm should indicate that he has hyperinflation of the lungs. So, what's your working diagnosis, doctors? I hope you said acute exacerbation of COPD.
Oh yeah. Alright.
Acute exacerbations of COPD are common and typically present with change in sputum color or amount, coughing, wheezing, and increased dyspnea. During an acute exacerbation, patients often appear anxious and tachypneic. They may be using accessory muscles of respiration, usually have wheezes or rales, and may have signs of cyanosis. Although this could look like an acute exacerbation of asthma, asthma typically has a non-productive cough, often presents earlier in life, whereas COPD tends to present in midlife or later in life, being almost exclusively diagnosed in adults over the age of 40. Plus, asthma may or may not be associated with cigarette smoking, whereas COPD always tends to be. Although respiratory tract infections, whether they're viral or bacterial, are the most common precipitant, air pollutants are another common cause of acute COPD exacerbations. We must rule out other diagnoses that have similar symptoms such as pulmonary embolism, congestive heart failure, myocardial infarction, pneumonia, pneumothorax, and pleural effusion. Although our patient isn't cyanotic yet, it's important to assess all dyspneic patients starting off with ABC. That's airway, breathing, and circulation. Come on, guys. The severity of the exacerbation should be evaluated by history, examination, assessment of oxygenation using a pulse oximetry, and focused testing. Following questions from the medical history may help to assist in assessing the exacerbation, number of previous episodes and hospitalizations, other chronic conditions, current treatment regimen, history of intubation and/or mechanical ventilation, and duration and new symptoms. Physical examination signs of severity include the use of respiratory muscles, worsening or new cyanosis, unstable blood pressure and heart rate, altered mental status, and peripheral edema. Oxygen should be given with a target saturation of 88% to 92% or a partial oxygen level at about 60 millimeters of mercury. Patients with more severe symptoms, comorbidities, altered mental status, an inability to care for themselves at home, or whose symptoms fail to respond promptly to office or emergency room treatment should be hospitalized. If hospitalized, a baseline arterial blood gas should be ordered to evaluate for hypercapnia, hypoxemia, and respiratory acidosis. Ventilatory support with either non-invasive, such as nasal or face mask, or invasive ventilation, such as intubation, should be considered in deteriorating or critical patients. All acute exacerbations should be treated with short-acting bronchodilators. Combinations of short-acting agents with different mechanisms of action, such as beta-agonists and anticholinergics, can be used until symptoms improve. Systemic steroids shorten the course of the exacerbation and may reduce the risk of relapse. A steroid dose of 40 milligrams of prednisolone for 10 to 14 days is recommended. Exacerbations associated with increased amounts of sputum or with purulent sputum should be treated with antibiotics. A sputum culture should be performed because Pneumococcus, Haemophilus influenzae, and Moraxella catarrhalis are the most common bacterial infections. In milder exacerbations, treatment with oral agents directed against these pathogens is appropriate. In severe exacerbations, gram-negative bacteria such as Klebsiella or Pseudomonas can play a role, so antibiotic coverage needs to be broader. Measures taken to prevent COPD exacerbation should be discussed and reviewed at each patient encounter. The number of annual exacerbations can be reduced by receiving appropriate vaccinations such as influenza and pneumococcal, smoking cessation counseling, education about current medications and their proper use.
People need to stop smoking.
Break it down! But out! Yeah! It's cool to say no! But out! Smoking's got to go!
COPD, which stands for chronic obstructive pulmonary disease, is an umbrella term for progressive lung diseases where the most common ones are emphysema and chronic bronchitis. Many people with COPD have both of these conditions. According to the World Health Organization, it is not a simple smoker's cough, but a common disease that's often underdiagnosed, life-threatening, progressive, and irreversible in the chronic airflow obstruction that leads to difficulty breathing, coughing, sputum production, and wheezing. The most common initial symptom of COPD is cough, which is at first intermittent and then frequently becomes a daily occurrence. The cough is often productive of white, thick mucus. Patients will present with intermittent episodes of worsening cough with change in mucus from clear to yellow or green, and often with wheezing. These exacerbations are usually caused by viral or bacterial infections. As COPD progresses, lung function continues to deteriorate and dyspnea develops. Dyspnea is the primary presenting symptom of COPD. It also tends to worsen over time. Initially, it will occur only with significant effort, then with any exertion, and finally at rest. The time dyspnea develops, lung function, as measured by forced expiratory volume in the first second of expiration, FEV1, has been reduced by about half, and the COPD has been present for years. When evaluating the patient with dyspnea, it is important to consider other diagnoses. 85% of dyspnea causes are due to one of the following conditions: congestive heart failure, COPD, asthma, interstitial lung disease, pneumonia, and psychogenic disturbances including anxiety. COPD is so common that it's the third leading cause of death in the United States, affecting more than 16 million Americans according to the American Lung Association. And it's also the third leading cause of death worldwide, affecting more than 251 million people according to the World Health Organization. The biggest reason as to why so many people have it is due to tobacco smoking. I mean, we're talking like about 90% of COPD cases. And with newer research studies done, this also includes marijuana smoking. people who smoke tend to have a difficult time quitting despite struggling with COPD. Other etiologies include secondhand smoke exposure.
Well, if you want my opinion, boys, I think Mighty Morris is going to win the race. Oh, boy, that cigar.
Occupational exposures to dust like mining, cotton, silica, or plastics, exposures to chemicals, exposures to fumes from welding or heavy metals, or exposures to air pollution, especially for those living in the city due to outdoor pollutants like car exhaust, or indoor pollution such as poorly ventilated heating and cooking fires. And then there's that rare genetic deficiency in alpha-1 antitrypsin, which you'll find is more common in Caucasians and non-smokers who develop emphysema at younger ages, like under the age of 45. Emphysema is a condition that involves damage to the walls of the alveoli, which are the air sacs of the lungs. With this damage, the inner walls of the alveoli weaken and rupture, creating larger air spaces instead of small ones, thus reducing the surface area of the lungs and in turn reducing the amount of oxygen that reaches our bloodstream. During exhalation, the damaged alveoli cannot support the bronchial tubes, which then collapse and cause an obstruction, which then traps old air inside the lungs instead of creating space for fresh, oxygen-rich air to enter. People with emphysema are also known as the pink puffers. You can recognize them as they tend to breathe fast through pursed lips, making their skin look pink, their chests look barrel-chested, and with all this effort to breathe, they tend to be thin with muscle atrophy. Symptoms include dyspnea, especially upon exertion, coughing, wheezing, chest tightness, an increased production of sputum, ongoing fatigue, and ruddy cheeks.
Never envisioned that there's anything more with emphysema than being short of breath. But there's a lot more. Breathing is the most natural thing we do. We don't even think about it. Sometimes I have to decide whether I'm going to eat or breathe.
Lung examination reveals a 2-to-1 increase in anterior to posterior diameter, diffuse or focal wheezing, diffusely diminished breath sounds, hyperresonance upon percussion, prolonged expiration, and/or hyperinflation on chest radiographs. People with emphysema are more likely to develop pneumothorax or pulmonary, pneumonia, bronchitis, and other lung infections. Chronic bronchitis is a condition that involves constant irritation or inflammation of the lining of the bronchial tubes, often due to smoking. In chronic bronchitis, we have smooth muscle hypertrophy and contraction, as well as mucus hypersecretion leading to narrowed airway and difficulty breathing. Unlike acute bronchitis, also known as chest cold, that usually develops from a cold or other viral respiratory infection and usually self-improves within 7 to 10 days, chronic bronchitis is defined as a productive cough that occurs on most days for at least 3 months, with recurring bouts occurring for at least 2 consecutive years. People with chronic bronchitis are also known as blue bloaters. You can recognize them as they tend to be obese or overweight with peripheral edema due to cor pulmonale and blue or cyanotic around their lips and fingertips due to hypoxemia. Symptoms include dyspnea upon exertion, coughing with sputum production that can be clear, white, purulent, yellowish gray, or green. Rarely there could be hemoptysis, and definitely ongoing fatigue. Signs include dusky or cyanotic color, digital clubbing, elevated JVD, peripheral edema, increased respiratory rate, use of accessory muscles, and increased hemoglobin. Lung examination can reveal wheezing due to a narrowed airway, crackling or rales due to fluid in the alveoli, bronchi due to thickened mucus in the bronchial tubes, and prolonged expiration. People with chronic bronchitis are more likely to develop secondary polycythemia vera due to hypoxemia, pulmonary hypertension due to reactive vasoconstriction from hypoxemia, and cor pulmonale from chronic pulmonary hypertension. In diagnosing COPD, The primary diagnostic test of pulmonary function tests, PFTs, is spirometry, which measures how much air can be breathed into the lungs and how much air can be quickly blown out of the lungs. In normal lungs, the ratio of FEV1 to FVC is greater than 0.7. However, in patients with COPD, the ratio of FEV1 to FVC is less than 0.7, and both the FVC and FEV1 are reduced. As COPD is a chronic condition that is expected to worsen over time, routine follow-up is imperative. Spirometry is the best method to monitor lung function. COPD assessment test, also known as CAT, is a questionnaire given to patients every 3 months. The CAT is an objective tool to assess changes over time and the impact that COPD is having on a patient's life. Depending on the stage of the patient's COPD, pulmonary rehabilitation and possibly lung resection surgery should be considered with the appropriate specialist. For those who are at risk of developing COPD, prevention is very important to protect the lungs. The number one thing to encourage is to quit smoking and to avoid breathing secondhand smoke. Although smoking cessation does not result in significant improvement of pulmonary function, it does reduce the rate of further deterioration to that of a non-smoker. And it significantly reduces the risk of developing other comorbidities such as cardiovascular diseases and cancers. Then, it's important to discuss wearing a mask at work to protect their lungs if their work involves exposures to dust, chemicals, fumes, or indoor-outdoor pollutants. And of course, discuss getting recommended vaccines such as the yearly flu vaccine and pneumococcal vaccine. According to the National Heart, Lung, and Blood Institute and the World Health Organization, Stage 1, which is considered mild COPD, is when the patient's spirometry findings reveal having an FEV1 to FVC ratio of less than 0.7 and has a FEV1 of greater than or equal to 80% predicted, despite if they're with or without symptoms. For these Stage 1 COPD patients, inhaled short-acting bronchodilators, including beta-2 agonists like albuterol and anticholinergics like ipratropium, are prescribed. Inhaled medications are preferred over oral as they tend to have fewer side effects. In Stage 2, which is moderate COPD, the FEV1 to FVC ratio is still below 0.7, and the FEV1 is reduced further to 50 to 80% predicted, whether or not they have symptoms. For these Stage 2 COPD patients, on top of the inhaled short-acting bronchodilators, we now have long-acting bronchodilators, including inhaled beta-2 agonists like salmeterol and inhaled anticholinergics like tiotropium added to their medication regimen. Long-acting bronchodilators are more convenient and more effective than using a short-acting bronchodilator. However, they're more expensive and does not replace the need for short-acting agents for rescue therapy during exacerbations. In Stage 3, which is severe COPD, the FEV1 to FVC ratio is still below 0.7 and the FEV1 is reduced even further to 30 to 50% predicted, whether or not they have symptoms. For these Stage 3 COPD patients, on top of the bronchodilators, we now have added inhaled steroids like fluticasone, triamcinolone, and mometasone to reduce the frequency of COPD exacerbations. Inhaled steroids are preferred over oral steroids, as long-term treatment for oral steroids can cause myopathy, osteoporosis, and glucose intolerance. Although continuous prophylactic antibiotic use decreases the number of COPD exacerbations for a few years, there is no decrease in mortality, and the risk of antibiotic resistance makes this a controversial issue. In Stage 4, which is very severe COPD, the FEV1 to FVC ratio is still below 0.7, and the FEV1 is less than 30% predicted or less than 50% predicted with chronic hypoxemia. For these Stage 4 COPD patients, on top of the bronchodilators and the inhaled steroids, they are on long-term oxygen therapy and are in consideration for surgical interventions like lung resection surgery. Oxygen therapy is recommended when partial oxygen is less than or equal to 60 millimeters of mercury and there is polycythemia, pulmonary hypertension, or peripheral edema suggesting heart failure. Being on oxygen therapy is the only intervention that is shown to decrease mortality and must be worn for at least 15 hours a day. Since there is no cure for COPD and since pharmacologic treatment cannot reverse lung changes or modify long-term decline in lung function, I have listed a complementary integrative approach to help relieve symptoms, prevent and slow disease progression, and reduce future exacerbations. Phew, that is a wrap for COPD. There's going to be another COPD in the future. Anyways, I am sorry for the long video, and I'm sorry for the delay of posting it 2 weeks later, but I hope you can forgive me. Anyways, this is Dr. Sola signing off. See you next time. Mwah.
Don't smoke. Don't ever smoke.